Hello, everyone. Thank you and welcome everyone to our Research Connect series. My name is Amy Thatchell and I'm a CDTRP trainee. I'll be facilitating today's webinar. First, I'd like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. Today, I am personally joining you from Vancouver, which is part of the traditional territory of the Musqueam, Squamish, and Tsleil-Waututh First Nations. I'd like to encourage everyone to take a moment to reflect and write your own land acknowledgement in the chat box. We would also like to acknowledge Astellas, AstraZeneca, and the CIHR, whose generous support has enabled us to host these sessions. Before we dive into the main content for today, I'd like to pass it off to Erica for some general CDTRP updates.
Thank you, Amy. Today I have one announcement for everyone, and it's a save the date for our PFD forum. This year's Patient, Family, and Donor Research Forum will be held virtually on June 13th and 14th. Registration is free and can be done in the link that I will provide in the chat box. Thank you.
Okay, so before I introduce our speaker for today, I have a few housekeeping notes. Today's session is being recorded and will be posted on the CDTRP website and YouTube channel. During the presentation, please keep your mics off. If you have a question or a comment, you can raise your hand with the raise hand button on Zoom or type it into the comment section. I'm pleased to introduce our presenter for today, Dr. Basil Nasir. Dr. Nasir is a thoracic surgeon at the Centre Hospital de l'Université de Montréal. After completing a general surgery residency at the Mayo Clinic in Minnesota and a cardiothoracic surgery fellowship at the University of Alabama in Birmingham, he completed a fellowship at the CHUM in advanced minimally invasive endoscopy techniques. He subsequently completed a second fellowship at Duke University in lung transplant. The CHUM hired him in 2018, where he has been working as a thoracic surgeon, specializing in treating malignant and benign diseases of the lung, esophagus, and mediastinum, in addition to lung transplantation. So we're all very excited, and I will hand it off to you now, Dr. Nasir.
Okay, thank you, Amy, for that introduction. I'm gonna go ahead and share the screen. Can everybody see it?
Yep.
Okay. So let me just get myself set up here. Okay, well, first I'd like to thank the CDTRP and the Research Connect staff for their kind invitation. My voice is a little bit raspy. I am getting over a cold, so forgive me for that. I should mention that some of the people at the CDTRP have been involved at the work leading up to this point. So I'm glad to be able to share the work and the results of this with you today. So let's just dive right in, and specifically, what is the question? And I'm going to start by giving you some background on the topic. From watching previous Research Connect videos, I know that there's a vast audience. It's quite diverse with different backgrounds and expertise. I try to tailor this talk so that it resonates with most people or as much of the audience as possible, but forgive me if I do stray from that path slightly. So I'd like to start off by giving some of the background on how we came to define the question that we're trying to answer with this trial and why a trial is needed at this point. As you all know, lung transplantation is the only definitive treatment for patients with end-stage irreversible lung disease. And despite improvements, severe complications are still pretty common. Intraoperative hemodynamic management is vital and important for the success of lung transplantation. And there are several reasons why we could have problems with hemodynamics. These may result in complications such as strokes, kidney failure, and other catastrophic complications. Yet, lung transplantation is one of the most taxing operations that a person can undergo in terms of stress that it imparts on the heart and lungs. It's certainly one of the most stressing operations that I perform. And there are many reasons that these hemodynamic changes occur during transplantation. Bleeding is a common cause. Pulmonary artery clamping may put some undue stress on a heart that's already been stressed by the disease process. And also the mediastinal manipulation that is needed to facilitate access to perform the lung transplantation. All of those are associated with a reduction in the cardiac function somewhat during the transplantation. So our solution to this is to use a machine to assist us in providing heart and pulmonary support during the lung transplantation, and into helping in restorative function to perfuse the body with oxygenated blood. There are several options, of which the most known is the heart and lung machine that we traditionally use during cardiac surgery. They all really have the same basic setup, which I'm going to try to illustrate here using this cartoon. Here we have my attempt at making a heart and lung block. The process of mechanical pulmonary support involves taking blood directly from the venous side of the heart and running it through an oxygenator. This oxygenator would take on the function of the lungs and produce the gas exchange necessary to remove the oxygen, to put the oxygen into the blood and remove carbon dioxide, resulting in oxygenated blood that would be pumped through a pump and back into the left side of the heart, into the aorta, and to the rest of the body. Depending on how much support you desire to do, that will dictate how much blood you remove. So if you want to do full support, you would try to remove as much of the blood as possible, bypassing the heart and running it to the machine. Whereas if you desire partial support, then you only need to take a certain percentage of that blood. During lung transplantation, partial support is by far the most commonly used scenario. Whereas that cartoon does a good job of illustrating the basics of mechanical support in the heart and lung machine, it oversimplifies it to a certain extent. And here, this picture shows a standard heart and lung machine used during cardiac surgery. As you can see, the machine is quite complex, but I would like to turn your attention to this specific aspect of the machine. I don't know if it shows up well, but that's the reservoir. And when you do full support, that's the part of the machine that houses the blood and keeps it in there as you manage the cardiopulmonary machine, the heart and lung machine. When performing full support, the blood will stay there in contact with air. And this interface of air and blood is what creates a lot of the inflammation that causes some of the complications related to the heart and lung machine. It's also the reason why we need to give heavy doses of a blood thinner to offset the complication, the coagulation that results from using the heart and lung machine. But up until recently, this was really our only option to perform heart and lung support during lung transplantation. And it's because of all these changes, bleeding and systemic inflammation is more likely when using a heart and lung machine. And as with most things in medicine, one must weigh the risks and benefits of an intervention. And because of that, most centers use the heart and lung machine selectively only in cases where the benefit was felt to outweigh the increased incidence of bleeding. That certainly was the practice in all Canadian centers. To elaborate further, surgeons categorize lung transplant recipients into three groups. On one end of the spectrum, there are patients where mechanical cardiopulmonary support or the use of the heart and lung machine is mandatory. These are patients where the lung disease is so advanced, it puts a lot of stress on the heart, and the heart is at the limit of failure. Now, this heart will recover after a lung transplant almost immediately, but during the lung transplantation, the stress imparted by the operation may be just enough to tip it into full failure, and that would not be compatible with life during the lung transplantation. In such patients, cardiopulmonary support or the heart-lung machine is mandatory. On the other end of the spectrum are patients who have normal heart function and who have adequate lung reserve to sustain, to allow us to be able to do the lung transplantation on one lung while the other lung is being sewn in. And these patients, cardiopulmonary support probably adds very little. And so people are less likely to use the heart-lung machine in this setting. And then you have the group in the middle, where these are usually patients with normal heart function, but they have one or two risk factors that may make them at higher risk to having cardiac or pulmonary problems during the transplant. And these patients are obviously the most interesting group. It's also the group that has the most variability in their management. Different centers have different approaches on when to use cardiopulmonary support. In fact, different surgeons within the same center would have different thresholds on when to use cardiopulmonary support. So many of you might be thinking, well, if the reservoir is such a problem, why not just get rid of it? In fact, why not get rid of just everything associated with the cardiopulmonary machine and strip it down to its basic function? And so you have just a pump and just an oxygenator. And if you do that, then this is what you get. ECMO. Some of you may have heard that term, and ECMO stands for extracorporeal membrane oxygenation. In the real world, this machine here is the real world version of the cartoon that I showed you earlier. However, as you start taking away things from the cardiopulmonary machine, from the heart and lung machine, and you reduce it to its simplest function, you also reduce some of the flexibility associated with it. Compared to heart and lung, cardiopulmonary bypass or the use of the heart-lung machine, I'll use cardiopulmonary bypass and the heart-lung machine interchangeably. They mean the same thing. But compared to ECMO, cardiopulmonary bypass is much more flexible. You are able to do much more things. You're able to more easily go on full support. You can go on full support with ECMO, but it's a little bit more difficult. But since we take away the reservoir, we also take away the bigger disadvantage of the heart-lung machine. That is the higher incidence of bleeding and the higher incidence of inflammation. There's still a slight increase in bleeding, but it's to a much lesser extent than you would see with the heart and lung machine, the standard one. However, the development, as with the development of these changes, with the development of ECMO, it changes things a little bit, and it changes things with regard to how you weigh the risks and benefits of using cardiopulmonary support. We just established that bleeding is associated with using of the heart and lung machine, and that was a barrier to its use. And given that ECMO can do the same thing that a heart and lung machine to a lesser extent, but maybe sufficient enough for a lung transplant, it also does it with a less risk of bleeding. Then perhaps that changes the risk-benefit dynamic in favor of using more circulatory support. I personally think the answer is yes, that we should be using more circulatory support. Given the incidence of complications with ECMO compared to the heart and lung machine, we believe that more liberal use of ECMO will result in more hemodynamic stability and less hypoxia. Consequently, this will probably reduce the complications related to those two things. But it's not really clear how much more should we use ECMO. Should we use it a little bit more, a lot more, maybe go all the way to use it on everybody? And that's why I think this makes a good question for the research trial. Should we use ECMO more? Should we use it routinely, or should we continue using it selectively? So this leads to the main objective of the trial, which we will try to answer by implementing it. So what does the literature show about this question? The spoiler alert is that there's not much agreement to this. And I'll try by illustrating how the advantages and disadvantages of each approach differ. So whether employing a routine or an on-demand or selective strategy, each method has its advantages and disadvantages. Whatever you say about one, the converse is true of the other. In the on-demand strategy, hemodynamics are slightly more erratic. The blood pressure goes up and down more frequently during these cases. However, if you initiate ECMO on demand appropriately, you would be able to mitigate some of the complications that would be associated with erratic blood pressure. The major drawback of the on-demand approach occurs when there's a delay in instituting ECMO during periods of hemodynamic compromise. This could be to a number of reasons, such as technical difficulties in obtaining vascular access when you're, during periods of high stress, or failure to predict impending cardiovascular deterioration. The most extreme example of this is if the patient's heart or lungs just completely stop to function. And then you're trying to get the patient on ECMO with very little time, and you do it with rush technique. And the sacrificing of optimal technique results in an unideal situation, which can result in catastrophic complication. On the other hand, the routine approach has the advantage of providing a smoother hemodynamic course. The blood pressure is much more smooth, the management's a little bit easier, and crash on pump scenarios are exceedingly rare. But this comes at the price of more bleeding and more systemic inflammation. Consequently, the major advantage of routine ECMO is that it exposes the patient to more blood products, more bleeding, and more surgery or takebacks for bleeding. Obviously, this means that the main advantage of the selective group is that it reduces bleeding and there's less need for blood products or less need for further surgery. The Vienna group are strong proponents of using ECMO routinely in everybody. In 2018, they published this study showing the survival advantage of patients who had their transplant done on ECMO. But the major problem with this study is they compared their contemporary group where they did ECMO on everybody to a historical group where they did not use ECMO. Therefore, it's really hard to account for the era effect of this cohort. Did the outcomes in ECMO improve because of ECMO itself, or because, as with everybody else in the world, lung transplant outcomes just improved with time? Now, that same group in 2020 described a second experience of using ECMO for everybody. They had switched their practice after the initial study to routine ECMO, and 2 years later, they published these results. And you can see they have some pretty good one-year survival at about 86%, which is slightly higher than average. But when you look at primary graft dysfunction, and that's a fancy way of saying the lungs just don't work in the first few days, the incidence is really low. It's probably a little bit lower than what we expect from other centers. They hypothesize that by using ECMO, they direct the blood away from the heart and the newly transplanted lung and reduce the edema or the swelling that comes from that, which is the hallmark of primary graft dysfunction. Unfortunately, the lack of the control group did not address the critiques of the older study, but they did publish their complication data. And here they show that ECMO is not risk-free, and there are some complications directly attributed to the ECMO use. Additionally, their bleeding rate was slightly higher than what we expect, which is in keeping with use of ECMO for everybody. And so although ECMO causes less bleeding than the heart-lung machine, it still causes a slight increase of bleeding, albeit at a lower risk. The study generated some commentaries, as can be seen from this PubMed screenshot. There are at least 4 responses, all from authors that are American, and they all had very similar results, very similar comments. They all commented that the study had several limitations, mainly its retrospective nature, the lack of a comparison group, and the fact that the Vienna group does not really compare well to the North American experience. The Vienna group had a much higher incidence of COPD. That was the most of their lung transplants. That's a slightly lower risk group of patients compared to the North American experience, where we mostly have fibrosis and ILD patients. Now, finally, the American Association of Thoracic Surgeons published their 2022 expert consensus document on the use of mechanical circulatory support during lung transplantation. They issued 36 recommendations, but there was no definitive recommendation for or against routine or on-demand intraoperative ECMO. I'd like to highlight specifically two recommendations. The first here is that they state that ECMO is good, but the language is vague and does not clearly indicate a preference towards routine or a selective approach. They do suggest that ECMO should be routinely performed when there is moderate pulmonary hypertension, but that's really the only definitive statement they make on the topic. So despite multiple publications, there's no definitive conclusion on when to use ECMO, whether to use it routinely or selectively. Each strategy has its advantages and disadvantages, and proponents can be found on each end of the spectrum. Therefore, equipoise exists, and the question should be addressed. And I think that a randomized control trial is the best way to address this controversy. So we finally arrive at the main topic and the discussion of the trial. In 2021, we created a group of representatives from different specialists in each of the lung transplant centers in Canada. There are 4 centers, and they're all depicted here. And some of you may recognize some of the names on this slide. And over several meetings and discussions, we designed a trial that would be applicable to all 4 centers. Now, in addition, we also enlisted the help of Tim Ramsey from Ottawa to provide statistical support. That meeting was facilitated by the CDTRP, and Katie, I think, who's on this call, facilitated that meeting, and you have my gratitude for that. After multiple discussions and multiple meetings, consensus was finally achieved and Revolution was born. Revolution stands for routine versus on-demand intraoperative extracorporeal membrane oxygenation during lung transplantation. It's a prospective, pragmatic, randomized controlled trial with 2 treatment arms, routine ECMO versus on-demand ECMO. The underlying hypothesis is that both strategies are equivalent, and there's really no advantages for one or the other, so centers could do their preference. There are 2 arms. In the first arm, the routine arm, all lung transplants will be performed with ECMO, regardless of hemodynamic status. In the second arm, ECMO, the lung transplantation will be started without cardiopulmonary support, and ECMO will be used selectively at the discretion of the transplant team, depending on indications achieved during the actual transplant operation. Reasons for instituting ECMO are several and will be documented, and they include inability to maintain adequate blood pressure or hemodynamics, inability to tolerate clamping the pulmonary artery to facilitate the transplantation, inability to maintain adequate gas exchange, whether before or after the lung transplantation, or inability to expose the pulmonary hilum to be able to safely perform the lung transplantation. And finally, we leave the discretion to the transplant team to decide whether or not they think it's safe to proceed with or without ECMO, even if the above-mentioned criteria have not been achieved. Now, the primary outcome that we chose was this composite outcome that includes death, disabling stroke, grade 2 or 3 primary graft dysfunction, major bleeding, vascular complications, and stage 2 or 3 acute kidney injury based on the KDIGO classification. Now, that's a lot of things, and that composite outcome is pretty complicated. We used the composite outcome with multiple outcomes as our primary endpoint, and that is because we felt that each endpoint was critical to assessing the effect of intraoperative ECMO strategy. The primary outcome chosen has not been used in previous reports and has not been formally validated. However, there were vigorous discussions amongst the members of the group, many of which are leaders in lung transplantation, worldwide renowned leaders. And this included discussions about the specific components of the composite outcome and whether one of them would be a better outcome. There was consensus, however, that the composite outcome is probably the best way to assess the effectiveness of the strategy. And that is because we feel that by examining each one individually doesn't give a holistic picture. You'll get a better picture of how it's assessed when you examine all these outcomes collectively. Now, of course, that introduces some statistical anomalies, but we felt that it is worth it to proceed with that, even knowing that fact. Regarding inclusion criteria, any patient of 18 years of age or older who is listed in any of the participating lung transplant center will be screened for inclusion in the study. There are some obvious exclusion factors here, such as multi-organ transplantation and transplantation and retransplantation. The other exclusion criteria was a topic of much discussion, and we had to exclude patients who had to be done with mechanical circulatory support, the first group that we mentioned when I first introduced this topic. In other words, this is the group of patients where we felt that doing the transplant off ECMO was not safe, but defining that group was very, very challenging, and there was no consensus on how to define that group. Severe pulmonary hypertension is known to be a factor for not using ECMO, so we would exclude patients with severe pulmonary hypertension, but there's no clear consensus on what defines severe pulmonary hypertension. These numbers are based on expert opinion and discussion amongst the group. We also decided to exclude patients with moderate to severe right ventricular dysfunction and patients with severe left ventricular dysfunction, which is defined here as an ejection fraction of 50% or less. Regarding obtaining consent for these trials can be challenging, and we have to be very pragmatic about how we approach this. And so patients will be screened for participation in the study once they are activated on waitlist. Patients with exclusion criteria will be excluded, and patients who meet eligibility criteria will be enrolled into the study. Management of these patients will be as per the institution's guidelines and usually involves several clinical visits while they're on the waitlist. During these visits, the patient will be evaluated for development of exclusion criteria and excluded from the study should that happen. Otherwise, the patient will remain on the transplant list until a donor is identified or until they are removed from the waitlist. The average waitlist for a lung transplant in Canada ranges from 3 to 5 months. Therefore, significant time could pass between study enrollment and the patient's transplant. And the patient's clinical status may change, and you may have a completely different patient on the day of your transplant compared to the one that you saw when you first enrolled them. Specifically, therefore we decided that the final decision to randomize will occur at the day that the transplant is performed. Specifically, once a donor lung is confirmed, the eligible patient is brought to the operating room, general anesthesia is induced, and the patient is intubated. An inhaled pulmonary vasodilator is initiated to treat the patient's pulmonary hypertension, and monitoring lines are placed. We will be looking for exclusion criteria, and if we identify them, then we would exclude the patient from the study. However, in the absence of exclusion criteria, we would randomize them to one of each group, to one group or the other. This randomization method ensures that the patient who develops exclusion criteria while on the wait list are not inappropriately included. Of course, one option would be to randomize patients from the time of their transplant. However, this is problematic for 2 reasons. First, transplantation is an unplanned procedure occurring once a deceased donor is identified. Second, the time between when a recipient is notified of their transplant and the actual operation is very stressful for the patient. Approaching a patient for consent about this study may not be the most ideal time to perform informed consent. In fact, some of the patient partners that I met through the CDTRP, who I think I saw on this call, have helped me develop this consent process. These patient partners have astutely advised us that the consent while on the wait list would be better from their perspective. It's less stressful and gives them time to review the study comfortably and provide more informed consent. Now, the sample size calculation was also an issue to discuss. Revolution is a trial that's designed as an equivalence trial, and a power calculation was performed using the method of Blackwelder. Now, I'm not going to get into the statistics because that's just beyond me, and it's really all the work done by our statisticians and specifically Tim. But we plugged in these numbers, and the power and alpha numbers are pretty standard numbers that are used. The equivalence margin, the expected incidence of primary outcome was not reported in the literature, so we based it on the outcomes from the 2019 CHUM data, where we had an incidence of about 60%. So just to err on the side of caution, we used 50% because that would give us the highest sample size. Regarding the equivalence margin, there is no consensus on what an appropriate equivalence margin should be. And we canvassed our colleagues and discussed with others, experts in the field. And we can conclude that an absolute difference of about 10% would be enough to change practice in favor of the superior approach. Anything less than that would not be enticing enough. And once we plugged in, once we plugged in the number, we got a number of sample size of 620 patients or 310 patients per arm. Now that sample size is too big for a single center study. Therefore, we had to enlist the help of other centers. And so that brings us to the feasibility study. Our initial goal was that Revolution be feasible within 3 years. And given that CHUM performs 18% of lung transplants in Canada in 2019, assuming similar recruitments from other centers, we concluded that if CHUM was to recruit 112 patients over 3 years, then that would make the study feasible. Now, we implemented the feasibility study over 6 months instead of 3 years. And we conducted that study starting in September of 2022. And we determined that if we were to recruit 1/6 of 112 or about 19 patients, then the study would be feasible in that 6-month period. The study was completed in March 15th of 2023, and we exceeded our recruitment goal. Specifically, 44 patients were screened for the study. 3 patients did not provide consent, and 11 patients had exclusion criteria. 30 patients had been recruited to the study, of which 29 patients underwent transplantation, with 1 remaining on the list awaiting her transplant which happened after the conclusion of the study. At the time of their transplant, 1 patient was excluded because they were found to have developed an exclusion criteria, leaving 28 patients to randomize 14 in each group. Looking specifically at the results, and starting with the routine group, there were 14 patients randomized in this group. The majority of patients had interstitial lung disease. And in this group, there was 1 protocol violation where access to the aorta made it impossible to safely perform ECMO. And so this patient was done off ECMO, even though the study stipulated this should have been done on ECMO. The remaining 13 patients were done on ECMO as per the protocol. In the on-demand group, 14 patients were randomized, again, similar breakup in the disease process. And of these, 10 patients were performed off ECMO, and only 3 patients were crossed over to ECMO because of the reasons shown there. There were no crash on pump events in this study. Although the numbers are too small to draw any major conclusions, we thought it might be just interesting just to look at the complication data. The composite outcome occurred less than we expected in about 41% of patients or 11 patients. Sorry, 41% of or 11 patients. The rates were pretty similar in both groups. There was 1 mortality at day 7 due to a malignant arrhythmia. And most of the complications were due to kidney injury that occurred closer to the 7-day period as opposed to the first few days. Based on these results, we determined that Revolution is feasible within a 3-year recruitment period with a low likelihood of a failed trial. But we also made a few changes. First, we changed the primary outcome from 14 to 3 days. The main reason being is that we observed a bunch of kidney failures that happened about 7 days or 10 days, and they were more related to immunosuppression medications or development of another complication, and were not really related to your intraoperative ECMO strategy. So we decided to just focus on the first 3 days. Now, we will be tracking the 14 days as primary of the secondary outcomes, but not as part of the first of the primary outcome. Second, we changed the definition of the LV dysfunction to include 45% as opposed to 50%, and that's because we excluded a number of patients who had an LVF of less than 50%. Those patients went on to have their transplants done off protocol, off ECMO, and they did fine, so it alleviated any concerns about randomizing into the group. Finally, just to add a level of safety, we increased the recruitment period to 4 years instead of 3. So what's our next step? Well, the first step would be to get funding, and we have calculated the budget needed for the study. It's mainly due to compensation of research personnel and management of the patient of studies. There's really not a lot of raw materials. We calculated a budget of about 1.1 million Canadian dollars to run the study. We don't really have a lot of options for funding that we could identify. CHR seems like the most likely source. We did apply twice. Unfortunately, we were unsuccessful. But the most recent critiques were favorable. So we feel good about proceeding with the second submission. Second is regarding recruitment. The total Canadian annual volume for lung transplants is about 410, with approximately 2/3 of these patients being eligible for the study. 1/3 will have exclusion criteria. The planned recruitment rate assumes that all centers would recruit at a similar rate. However, this assumption may be a little bit naive. And so in order to mitigate this risk, we have increased the trial period, as I mentioned in the previous slide. Additionally, we have solicited the interest from other centers outside of Canada, specifically in the UK and in the US. And we have, by increasing the number of the patient pools that may be eligible, we would mitigate against the risks of a failed trial due to lower recruitment from other centers, or even our center. And then finally, we did ask ourselves whether it would be helpful to enlist the help of a clinical trial unit. That is a unit that specifically dedicates itself to the day-to-day running and management of the trial. And so we will be exploring that with some interest. And so here we have a proposed timeline. We will be hoping to apply for funding again in the fall of 2024, and aim to, if everything goes as planned, open the study for enrollment in about a year, and maybe conclude the study 3 to 4 years after that, in spring of 2028 or 2029. And so that concludes my talk. I'll be happy to take on any discussion or questions. I presume I should stop sharing at this point?
Yes, please.
Thank you, Dr. Nasir, for the excellent presentation. I'll open the floor up to any questions.
I can start. I have a surgical question.
Yeah.
Is there a difference between putting a patient on the CPD and ECMO?
Oh, in terms of like the actual technical aspects of it?
I'm assuming they go into the vena cava and the aorta, but
Yeah,
are they
so
both the same?
the actual cannulation is the same. The only thing that's different is the machine and the amount of heparin that you give. So anybody who can put a patient on cardiopulmonary bypass can't put a patient on ECMO and vice versa. The actual procedure is very similar.
Thank you.
No problem.
I also have a question, Dr.
Yeah.
Nasir. Can ECMO be used in the pediatric population?
Very frequently it is, yes. Much more complex because you're limited in terms of access to vessels. You don't have as much options the smaller the child is. But ECMO is very, very commonly used. In fact, before ECMO became mainstream in lung transplant, it was mainly used in children for several reasons outside. It's not very common to do lung transplants in children, but it was more used in the setting of cardiac failure. So a lot of the data that we see with regard to ECMO is especially with the earlier implementation, was derived from data from children.
Okay, thank you. I think there is a question or a comment in the chat from Sean. Have you been able to present your findings to the CST lung group or to ISHLT? What has been the interest / uptake from your surgical colleagues across Canada?
Okay, good. That's a lot of questions, but I'll try to answer it. Have we presented? So we have not presented to the CST the feasibility study yet. We did present it to. You may or may not be familiar with the CST having a lung research interest group, that is led by Aleem Hirji from Alberta. You mentioned Alberta earlier. So we did present initially the idea of this study at that meeting, and that's how we had some of the contacts established to move on with by establishing the group that I mentioned in 2021. We haven't presented the result of the feasibility study at the CST, but we did present it as a poster at ICHLT in Denver of last year. And we just recently published that as in the Journal of Heart and Lung Transplantation as a brief communications. So the main reason for doing that was to, like you said, like you astutely pointed out, was to solicit interest from surgical colleagues. And to be honest, it's been variable. It ranges from people who are very, very interested to the point of wanting to recruit with us. So that came from the English group. We had several people who are probably going to recruit with us. To some people who, yeah, it's a great study and will be recruited, but let us know when you have money, which is fair. And then there's also the sort of, yeah, it sounds like an interesting study. We're not interested in recruiting. Let us know when you have the results. We'll be very, very interested to know the results. To go so far as to have some critique of the study and why they don't think that it's the best way to approach. So thankfully, most of the response has been positive. I mean, the vast majority has been positive, that the trial is needed and it should be done. But I think most people acknowledge that it's going to be a steep climb to get this trial going. But if we have cooperation from all 4 Canadian centers and the 2 centers in England, and we have Cedars-Sinai from the US, then we should be able to do this trial. Once it gets going, it should be very feasible. I'll find out a little bit more next week, because next week we're going to Prague for the ISHLT, and I'll be able to really gauge interest now that the publication has happened. I hope that answers Sean Delaney's question. I think I see Katie put up her hand.
Hello, hi Basil. It's nice to see you again. Thanks for
Nice
coming,
to see you.
giving us an update on this project. I think you alluded to my question a bit in your answer to Sean's question. I was going to ask, or I am going to ask, what you think an international trial would look like, which kind of areas you were targeting, and how that would change your trial rollout plan, like sharing data internationally and the consent processes and what that would look like.
Yeah, going outside of Canada, this is why we limited to Canada before, because we thought that we had the numbers to do it just in Canada. Part of the reason is also because I know the Canadian colleagues very well, and I know their practice very well. We know that there's enough similarities that that won't be a confounding. When you start going outside to centers that you don't know, then you introduce that level of complexity, or how do I know that those centers? So you really can't just go to anybody. You have to go to centers that you either know or somebody that you trust knows them well enough to be able to tell you that their practice is similar enough to yours. For example, like I mentioned Vienna a lot, Vienna would not be a good center to go to. They don't have equipoise, and they've completely just changed their practice to routine practice. They would not be interested. So that limits the number of centers that I can approach. And we don't need a lot of more centers. Of course, it depends on the center volume, but I've identified 3 centers that have been interested, and those would probably be enough. US is, you would think that the US would be a good area to start, but the US is very, very, very complicated when you start doing multinational centers. There's a lot of red tape, almost as much as Canada, but Canada's a little bit more, but because I'm in Canada, it makes it a little bit easier. But when you start going down south, it adds another level of complexity. Europe and Australia would be very, very good candidates. So we'll see. We'll see if we can get some of their interest. Now that addresses the first part of your question. How does it look in terms of rolling out the study? That is the main reason why I thought getting a clinical trials unit would be the best. If this was just a Canadian trial, I don't think it would be complicated to run it just with the level of support that I have at my own center. But now that we have decided to go international, adding the expertise of a clinical trial unit will streamline a lot of the things. They'll take care of a lot of these, the initiation, the center initiation, so as chasing people with emails, insurance. Once you go outside of Canada, then insurance becomes an issue, and all of these things that just are beyond my expertise. So I don't know how it would look like, but I don't envision that it certainly will be slower and it'll certainly be more complicated, but hopefully that'll be mitigated somewhat with the introduction of a clinical trials unit.
It'll
You
definitely
also
assist
asked about
your,
sorry. Yeah,
no,
go ahead.
go ahead. No, I was gonna say it could increase your opportunities for grant funding going internationally, because you could apply for funding in the different countries, but it would also it's going to also significantly increase your budget, especially one of the contract research organizations.
And it depends on the funding opportunities, because big trials in lung transplant research, surgical ones, there are not a lot of funding opportunities. I mentioned CIHR. There's accelerating clinical trials, which I know CDTRP is going to be a big part of. But as you know, that still hasn't taken off, and we don't know when it's going to happen. But I'm waiting very anxiously for it to happen soon, because that's one that we could target. But we'll have to see. Usually trials that, and this is just based on my conversation with my colleagues, getting funding from an outside institution where the primary trial personnel is not from that country is very, very challenging. But yeah, now you had also mentioned something about consent. We have our own consent process, and that was thanks to some of the people that are on this call that helped us with this. But every institution will evaluate their own consent process. Even in Canada, like when you go to Toronto, Edmonton, they're going to all evaluate the consent process and add or change according to their own institution how they want to see the consent process rolled out. This is kind of a what's the term I'm looking for? Like a map, like a basic outline of what we would expect. Yeah, I think I see Manuela. You're muted. I think you're muted still.
There we go. Sorry. Thanks for your presentation. It was a very good lectures about ECMO and lung transplantation. So my question now is more about the participants, your patients. So you said the clinicians, the majority of the clinicians are very interested in your findings and interested in trying it. But how was for your patients? How many of them said, yes, we want to try? How many, and what were the concerns from those that said, no, I don't want to participate in this study? And how did you address these barriers, understanding that it is a very special moment, the moment waiting for the transplant, and then knowing that they will receive the transplant and making a decision about joining a study, I assume it's very critical too. So how did you manage this?
Yeah, excellent question, and thank you for the kind comment. So the consent process, as you saw, I spent a lot of time talking about it because it is very common. You are walking a very fine line. Now, traditionally in surgical transplant trials, consent, like when you compare to say oncology trials or cancer trials, lung transplant recipients, what we've noticed is are more open to being enrolled in trials and in studies as opposed to on cancer trials. So I would say that the openness of participants was surprisingly good, even more than I expected, even knowing what I had just said. We had 3 patients that refused to consent, and those patients, I was involved very closely in the care of 2 of those patients. And those were patients that we met very quick. They had sort of developed they were candidates for the trial, but their lung disease was developing at a very, very rapid pace.
Mhm.
And I think there was a lot of stress surrounding everything, even though we kind of approached them at the beginning of the transplant. And, it was from the minute we introduced the study till, the actual transplant was, about a week or 2. But that period was really because I think they were seeing themselves deteriorating and the anxiety was too much for them to be able to sort of address that. So I don't know that I could address that anyway. If patients are stressed, and the one thing that I fear is a comment that one of my colleagues raised, and that is that some patients, when you consent them for the study, they may fear, despite all the reassurances, they may fear that, well, if I don't consent to the study, then maybe I won't get the preferential treatment that
Yes.
will come with being on the study. So we really, really try to go out of our way to make sure the patients understand that we are blinded to whoever's on the study until the moment of their transplant. So there's no preferential, like we're not going to preferentially give a donor to somebody we have to really make sure that point sinks home. And so the converse to that is I really don't try to push the study on anybody. I introduce the study, or my research personnel will introduce the study. We give them the consent form and the pamphlets. We describe it, and we tell them to take their time. Most of them don't see a problem. They sign right away and we tell them, go read the study. And when you come, if you change your mind, let us know. Some will want to spend a day or 2, and then we'll tell you, okay, call us back and we'll let us know. But we don't push anybody. And I think having screened 44 patients and only 3 refusing consent is a very, very good number. So I don't see a real need to mitigate recruitment from that standpoint. My fear is that if anything I will try will push me towards forcing the study on people. So I'm happy with kind of where we are with recruitment.
Yeah, thank you very much.
No problem. I think there was a chat question. How long were participants placed on ECMO? Variable. It depends. We put them on the ideal situation. I mean, the sort, not ideal, the prototypical situation. I think Erica asked that question.
Yeah.
Is you just place them on during the transplant. So open the chest, access the vessels, the aorta and the vena cava, like you mentioned, go on ECMO, do the 2, those are largely bilateral lung transplants. I think one patient was a single. So you would complete your lung transplant, and then right away, if the heart and lung function are good, you would separate them for ECMO. Now, I think in 2 patients, ECMO was necessary to remain postoperatively because of primary graft dysfunction, and those were less than 3 days. When we do the main trial, we'll have a few patients that are longer.
Okay, perfect. Thank you. Yes, because my main question was, because ECMO can go on a very long time. If I'm not mistaken, you can go 30 days.
Yeah. So I'll answer that. So yes, you can go longer. I mean, I think there's a publication of 3 months, patient on ECMO for 3 months. I think it might be, I can't remember if it's Toronto or Duke, that they had a patient on for 3 months on ECMO and they eventually got transplanted. That's different because that's before transplant. After transplant, ECMO that happens after transplant is due to one of 2 reasons. One, either heart dysfunction or lung, like it's somebody who had heart dysfunction because their RV is dilated and they just need a few days to recover. But that recovery happens within a few days. So it's rare to see ECMO go past that in the post-operative setting for heart dysfunction. The interesting thing about these patients, all of these would have been excluded from this study because they have bad hearts. So they would have to be done on support. So they would not be candidates for this study. The second indication is patients who have primary graft dysfunction, where you sew the lung in and it just turns white, doesn't work at all. And you would put them on ECMO. That occurs about 2 to 3% of the time. Those lungs will completely recover, at least in my experience. And they take anywhere from 2 to 7 days. The longest I've gone personally has been about 7 days. And so most of them will come off. The publications in the literature have shown, I've never seen anybody go past 7 days, but there is no publication every publication that addresses that there are no survivors when ECMO goes past 14 days in the post-transplant setting. Okay. In the pre-transplant setting, completely different. Oh, okay. Well, wow. Then, Shilpa, you should have your case maybe published. I didn't say there was no survivors. I said that there wasn't any that I was aware of that was published. Were you on for 14 days post?
Yeah, post. I had PGD, and so I was put on ECMO like during the transplant, and they took me off, I think 14 days post.
Yeah, okay, so you're okay, but you stopped at 14 days, so maybe the cutoff is true because I think it said beyond 14 days. But we've talked about this, and I think you recognize this as well, that that's the exception. That's not the norm at all. It's rare that we go past 14 days. Congratulations to having survived that, because that is a big feat. I can tell you, the longer the patient stays past ECMO, the more worried I become.
Yeah, I'm pretty sure it was definitely more than I'm quite positive it was up to 2 weeks on that. But yeah, I think when they took me off, it was like this needs to come off.
Yeah.
Yeah.
I don't blame you for having a hazy memory of the time. That's probably what
I have record of it too. I'm just trying to like I'm trying to remember the exact date, and I know I have it written down, but yeah, for
But it's
sure.
extremely rare. Extremely,
Yeah.
I can speak definitively to my experience and our
Yeah.
own transplants group experience. I can definitively say the longest I've gone is 7 days, and that's stretching it for me. Like usually I start to worry. Now we wouldn't pull the plug or anything,
Mhm.
at 7 days, just because I'm just saying that thankfully everybody that we've had has recovered at 7 days or unfortunately passed away before that
Yeah.
point. Other
I, s-
complications.
and I was still kept on a ventilator after that, like
Oh yeah,
longer.
no, ventilator
Yeah.
will go months.
Yeah. Yeah.
Yeah, it's very frequent, but ECMO, it's a little bit longer.
Mm-hmm. It's very
But Erica, just to address it, that's like a fraction. The patients that are selected for this study are sort of from the heart and lung standpoint are like slightly lower risk, because anybody with a lot of major risk factors would have to be done on support. So it wouldn't be safe to randomize them to the on-demand group.
Okay, so I see that time is just about up. Thank you everyone for your questions and comments throughout today's presentation. Dr. Nasir, on behalf of CDTRP, thank you again for presenting. If anyone has any additional questions, comments, or suggested topics and speakers, please contact Erica Croft at ekcroft@cdtrp.ca. I want to mention that all participants will receive an email asking them to fill out a survey, and we'd really appreciate it if you just took 3 minutes to complete that survey. So thanks everyone, and enjoy the rest of your day.